So the next speaker is going to be MOMIN ABDUL KAZI. He's an assistant professor at the Aga Khan University in Pakistan. And he has been very involved in research looking at digital and mobile e-health, mHealth interventions using technology as a research tool in studies and specifically looking at vaccination in public health. So MOMIN, if you would like to speak up, please.
Thanks, Naomi, and let me just share my screen again. All right. Can you see my slides and can you hear me well?
Yes, we can.
Great. Thank you so much. It's thank you, Tony, again, and it's a great opportunity. Thank you so much. So I'm going to you know, I've been already introduced. I'm going to walk you through on using mHealth-based interventions to improve vaccination coverage, and I'm quickly going to talk about what most of the presenters already have talked about, and they have emphasized stringently about the vaccination uptake and hesitancy. And so to further look into the current scenario of pandemic, there is further decrease in vaccination coverage, whether it's been low middle income country or high middle income country. And so again, you know, this question, and again, Anne actually also talked about the magic bullet and the magic pill. So are the text messages or the technology the magic pill we are talking about, and need of the time, and also if you want to think out of the box. However, it is pertinent to talk about the mobile phone coverage phenomena, which has leapfrogged, especially in the last decade, before we move forward. And one thing which is very important to look at is that, of course, especially in the last decade, there have been a leapfrog or a drastic increase in the mobile phone coverage. However, if we closely follow, there is an improvement in there is an coverage, global coverage of mobile phone. But if we compare that with smartphone, we still see a gap between high and low middle income country. That becomes important in sense that if depending on the intervention you want to use, and the intervention you want to the intervention you want to generalize. So right now there are around 7.7 billion mobile phone subscribers globally, with a very high volume using text messages. And if we talked about apps like WhatsApp, the numbers increase tenfold. However, again, looking at the type of intervention you want to use, and the type of the interventions and the devices which are being used by the population in which you want to implement your intervention. So the other important aspect which we need to look at is what are the basic requirements. This is even before you start planning for implementation of a digital health-based intervention. So some key issues is the mobile network accessibility or internet. Do the population have the mobile phone coverage? They have the internet or not? That's very important to look at. The usability of those devices or the phones, or the technology you want them to use. Are they literate, for example, for SMS-based intervention? Are they technology savvy? So technology savvy has nothing to do with literacy, and it could be someone who is highly educated but don't know how to use messages. Then things like availability of electricity and device security is important. It is also very important to look at what are the infrastructure and application. So you have the technology requirement. Have you looked into the regulations? What about the availability of the gateway and the portal through which not only you can look at the data, but if you want to monitor the data, you can do that as well. So shifting gear, I would like to talk just to give a 101 type of messages we can use for especially related to immunization uptake. So it could be SMS based or an app based message or an automated call. The messages could be reminders, just a simple reminder. Um, it could be an educational messages talking about specific on immunization, and it could be interactive. For example, the user can reply back pressing one and two, and it can be interactive. It can reply as well as get more relevant messages as well. One thing though is very important, and I will further talk about, is barrier-based messages. So what are the barriers due to which uh, 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 the caregivers are not immunizing their children, or even adolescents or adults are not vaccinating themselves, and then the messages should be around those barriers. So quick look at some of the systematic reviews. There have been some of the both in developed and developing countries, but most of the studies have been in US, and they have talked about that the digital push technologies have modest positive impact on vaccine uptake of the series, and also they have the potential for improvement in immunization coverage, both for childhood vaccination as well as adulthood vaccine. There's a recently published systematic review which specifically looked at different applications for vaccination coverage, and they looked at the cost effectiveness, usability, and acceptability, and participant perception. But most importantly, they looked at the uptake of vaccination outcomes. Out of 9 studies, there were 4 studies which showed significant improvement in vaccination coverage, and 4 studies out of 10 study also showed significant improvement in knowledge and learning related to vaccination. So these are very heartening information. However, the quality of these studies were moderate to poor, and more studies are needed in order to further evaluate these technologies. So not only we need to introduce new technologies, but we also need to understand what are the new or novel ways of evaluating this technology as well. Shifting gear as well, I'm going to talk about a couple of my studies in which we looked into the role of SMS-based intervention. So this is a journey a few years back in which this was a WHO-funded study in which we wanted to look at um, the role of SMS two-way messages for monitoring supplementary immunization activity, which is house-to-house polio immunization. And so we did a baseline survey of 3 towns in Karachi. The demographic data and the surveillance data was collected, and 2 messages in local language were sent asking them whether their child got vaccinated, or whether the vaccinator reached the household or not, whether the child got vaccinated or not. And so the data, the coverage information we got through messages, um, as compared to phone call, as compared to LQAS, which is WHO technique for household monitoring at the field level, the data was quite comparable. And not only the data was comparable, we were also able to look at the density map because we had the coordinates. So this was a very good technique remotely to using text messages to monitor the vaccination coverage. However, the problem was we couldn't go to house if you want to, for example, follow all the children in Pakistan. And so the second pilot strategy which we used the tower coverage area, or for cell phone provider tower coverage area, and we identified the area that this is the area we want to monitor for the immunization coverage, and without knowing the numbers, the messages were sent to the participant, and those who answered, we looked at the coverage area. So learning from this experience, in another study, so we really wanted to use this for routine immunization coverage improvement as well. So we use one-way SMS reminder messages in local language, and the messages were sent in the week the child was supposed to get, was scheduled for immunization for 6, 10, and 14 weeks. This is a schedule for low and middle income country according to API program. And so messages were sent in that week. And in this trial, there was a 5% increase in the intervention arm as compared to control arm. And key finding was that automated simple one-way SMS messages in local languages are feasible for improving routine vaccination coverage. However, SMS reminders alone might not make a big difference. So it is important to look into different type of messages and including SMS and automated call as well, and also to look into the perceptions and the barriers and text content according to local setting. So I'll move quickly to the next study in which learning from our previous experience, we designed this study in which we wanted to further evaluate the role of mobile phone based and automated call based messages for an urban and rural population, and in which we started with qualitative interviews, enrolled the child within 2 weeks of age, and followed them till 20th week of age, and then did interviews after the trial as well. For the study had 4 intervention arms: one-way, two-way SMS, and one-way, two-way automated call, or two-way is also IVR or interactive voice recording, and compared with the control arm. So weekly messages were sent according to the study arm and according to the barriers which were identified in the qualitative interviews and according to the language of their choice. The messages were developed to a very rigorous process because we really wanted to understand what were their barriers and personalize the messages and their content accordingly. And in the qualitative interviews before the trial, we were able to understand what were the barriers. So, namely, forget due date, lack of awareness, religious and community lack of religious community buy-in, low level of trust, and adverse effect. And we also were able to understand the language preferences, even the music in the automated call, and the specific dialogue they want, and the message, the voice of the messenger they want the message to be. And so 99% of the study participants had access to the mobile phone, with around 79% having simple function phone. There was a high population, 50% of the mothers were not educated, and 54% of the fathers own mobile phone. So in our per protocol analysis, we were able to see that there was statistically significant improvement in vaccination coverage in the intervention arm as compared to control arm. And especially in the IVR or two-way SMS, there was 10% increase in the vaccination coverage. And in our final model, we were able to see a 26% improvement in vaccination coverage in the IVR arm as compared to control arm. So the downside was that the intervention was useful, but too many families did not get the message. And information regarding families' perception of vaccination and daily life challenge really helped us to develop personalized mobile phone messages. The IVR-based intervention personalized according to the barriers should be and can be scaled up. So I just wanted to talk about what Anuradha spoke about, using geospatial maps for improvement and for monitoring of vaccination coverage. And so so unfortunately, Pakistan, we had XDR typhoid or subvaccine resistant Salmonella enterica serotype typhi, and so geospatial mapping was used to follow the outbreak, and the data through geospatial map helped us to understand the burden of XDR typhoid in different areas of Pakistan, and also in Karachi, one of the biggest city and the cosmopolitan city of Pakistan. And so using the information, the maps were used to look for catch-up vaccination, and also to strategize the planning for TCV vaccine. And so to finish off, the challenges in use of mHealth intervention can be further divided into who the ownership of the phone. This is more into low middle income country. Literacy could be important element, but we can always look into different strategies in the language of preference and pictorial, and the type of messages and vaccine hesitancy. This is single most important point which needs to be looked into. What are the barriers? What are the hesitancy? And personalize and have the messages according to those requirements. Lastly, I would finish up with uh, again emphasizing that personalized mobile phone messages and barriers are important. Barriers based intervention should be made and should be scaled up according to the program level. There is a need for well-planned, personalized, community-based knowledge translation and interventions. These interventions should not be in silo, but should be connected to the EPI program. So should be connected to different electronic immunization registries. Some of the registries. So there is a behavior change-based app we are working on, and also there are different e-registries used by lady health workers or EPI program. Those can be those have reminders or SMS system, but those should be connected. And lastly, these interventions should be adapted to AI and ML models so that so that they can be scaled up, and then in real time interventions can be adapted accordingly. So thank you so much.